Recording. All right, welcome back to the second part of the airway management slide set. We're starting right off with some advanced airways, and we're going to start with the dual lumen airway devices, and that includes the esophageal tracheal combi tube. And the combi tube is something that, when it came out years ago, was a great airway. It since I believe has been replaced by airways that are as good and certainly are simpler to operate and easier to insert, but there's still a few places out there that use the combi tube. It's indicated when you've got a difficult face mask fit or a difficult bag mask ventilation, because when using an esophageal tracheal combi tube, you eliminate the need for maintaining a mask seal. It's also a backup airway in the event that intubation is unsuccessful. And it certainly is something that somebody who is not trained to do endotracheal intubation could use to ventilate a person. The thing about this and the other supraglottic airway devices in laryngeal tube airways and laryngeal pillows and things like that we'll talk about, none of them will guarantee 100% to protect against aspiration, but it's certainly better than just a bag valve mask alone. Just having a little trouble getting it to advance to the next slide. There we go. The dual lumen airway devices. The contraindications, of course, is if somebody's got an intact gag reflex, or if they've got upper airway obstruction, you could actually when trying to insert it down the esophagus, could actually tear the esophagus. If they've got esophageal diseases like esophageal varices or esophageal cancers, then the insertion of the airway, certainly if the cancer or the varices are very high in the esophagus, could lead to rupturing those varices or not being able to pass through the cancers. If somebody's ingested a caustic substance like drain cleaner, we know that it burns all the way going in, and certainly the belief is that if they do vomit, it burns all the way coming back out. But the issue with the caustic substance ingestion, like drain cleaner, is when removing the combi tube, a person is certainly at great risk of aspirating or at least vomiting, and then they could aspirate that into their lungs. And aspirating a caustic substance into their lungs could lead to an aspirate pneumonia that could be lethal. The other thing to consider certainly is that the esophageal tracheal combi tube comes in two sizes. There's an adult size and there's a small adult size, but we can't really use the esophageal tracheal combi tube in people that are less than 4 foot tall. And that's where some of these other airways have become more popular, because as an example with the LMA, we can take that airway all the way down to a neonate, and with a king, we can take that airway all the way down to a small child. Pharyngeal tracheal lumen airways, or PTLs, very identical to a combi tube, a little more cumbersome to insert, a little more bulky, larger in size. They're indicated for people who are unconscious with no gag reflex over the age of 14. They need to be between 5 and 7 feet tall. Again, as I'd mentioned, they can't have a gag reflex, and it might be a backup airway in the event that you can't get somebody intubated. The PTL is contraindicated in people less than 14, people with a gag reflex. Again, just like the combi tube, because you're inserting it into the esophagus, people with esophageal varices or cancers, it's contraindicated in. Chronic alcohol abuse in patients who are alcoholics and chronically use alcohol, if their liver is in any sort of failure, the liver starts to when it fails, blood pouring into the liver backs up through the portal vein and into the esophagus, into the esophageal veins, causing esophageal varices. And it's just a varicose vein of the esophagus, and these certainly can rupture if you shove a hard tube down into the esophagus or with forceful vomiting. Here's an example of a combi tube. Again, if it's something that you use, you're familiar with the combi tube. It's something that we eliminated in our service, in our practice, many, many years ago with the advent of airways, esophageal airways that are easier to insert and cause less trauma. When inserting any sort of advanced airway device, we need proper personal protective equipment. We need to be able to get their mouth open. We need to have suction available. And if there's an oral airway, we need to remove the oral airway. We need to insert the combi tube and then auscultate for bilateral breath sounds and oxygenate with 100% oxygen. And maybe that's something that you do before inserting the tube. Remove the OPA, auscultate to make sure that you can ventilate the patient and they don't have an obstructed airway, and use 100% oxygen. The whole idea of using oxygen as part of ventilation prior to inserting any sort of advanced airway is that by giving them at least 6 good breaths with 100% oxygen, we eliminate or we replace the nitrogen that's in their body with oxygen. And by taking the nitrogen out of their bloodstream and replacing it with oxygen, we tremendously extend the length of time available to perform an advanced airway procedure. While you're ventilating them, certainly you want to assemble all your equipment. You want to check the cuffs for leaks. You want to lubricate the distal tip with the provided lubricant or KY jelly. You want to insert it midline, following the natural curvature of the pharynx, and then insert it till the black line on the combi tube is at the lips or the teeth. And then inflate cuff number 1 with 100 milliliters of air, and then inflate cuff number 2 with 15 milliliters of air, and then ventilate in cuff 1. You should see chest rise and fall because by nature the combi tube, like all esophageal tubes, is designed to end up in the esophagus. There's a very small percentage chance that it may end up in the trachea, and that specifically has to do with the positioning of your patient. So you go ahead and ventilate into cuff 1. You should get chest rise and fall. You should hear equal and bilateral breath sounds. And if you don't, then you ventilate in cuff 2, which would indicate that the tube is in fact in the trachea. If you get good chest rise and fall with tube 1, then tube 2 is open at the end, and if you're in the esophagus, if the patient were to vomit can shoot up out of that tube 2 with a combi tube. In fact, to the point where the company makes a vomit deflector, a little 90-degree elbow that goes on the end of tube 2 so that should the patient vomit, it doesn't spray out all over you but shoots to your partner on the left. Again, if the chest does not rise when you're ventilating into tube 1, then you move over to tube 2, and that would indicate that you are in the trachea and actually have an endotracheal tube. You want to confirm placement like you do with any advanced airway, looking for chest rise and fall, listening to lung sounds, listening over the belly. And once ventilation is confirmed, you want to continue ventilating through whichever tube is going to give you chest rise and fall. Supraglottic airway devices, or SADs as they're commonly known, include the laryngeal mask and the laryngeal tube airways. They're indicated when you can't get a good seal. They're indicated when intubation is unsuccessful or ventilation is difficult. And again, it's something that could be used in anybody that can insert an oropharyngeal airway. So if it's within your scope of practice to insert an OPA, then it is within your practice to insert a supraglottic airway. Contraindications to a supraglottic airway device include if you're not trained to use it, and then if the patient is at great risk of aspiration, because none of these airway devices, whether it's a combi tube, an LMA, a King, prevent or guarantee that the patient won't aspirate. Some of the advantages: it's really quick to insert. You get good tidal volumes. In fact, with some of the supraglottic airway devices, you're actually able to hook them up to a mechanical ventilator and ventilate the patient just as you would if they had an endotracheal tube. The training is simpler, requires fewer steps. It's unaffected by anatomic factors, like stenosis of the glottic opening, a tumor in on the vocal cords, all those things that anatomically may make intubation difficult aren't present when you're using a supraglottic airway device. There's very little risk of intubating the patient when you use a supraglottic airway device, because by design it is just designed to end up in the esophagus. There's less potential for trauma because of how they're designed. There's less coughing, laryngeal spasm, less sore throat, voice changes, things that occur when you use an endotracheal tube, particularly if if you have to force it past the cords. You can actually damage the cords, which certainly leads to things like voice changes or even loss of voice. The disadvantages, again, they do not protect from aspiration. If the mouth is not able to open wide enough, you may not be able to accommodate these type of devices. They are ineffective with abnormal respiratory anatomy, and they're not adequate if it requires a high pressure to ventilate or expand the lungs. Most of these cuffs that are on these supraglottic airway devices maintain a really adequate good seal as long as you don't exceed 20 centimeters of water, or 20 centimeters of or 20 millimeters of mercury pressure. And in patients who've drowned, in patients with stiff lungs, it may require more than 20 millimeters of pressure in order to get those lungs to expand. And in that case, the cuffs may leak in a supraglottic airway device. I will tell you that the King airway is the only airway that is FDA approved, the only supraglottic airway that is FDA approved to be placed on a ventilator, and it takes about 30 centimeters of pressure to leak air around those cuffs. Here's an LMA. Certainly, again, this is one of those airways that it was actually designed to be used in an operating room in a controlled condition, in patients who are NPO, patients who are dry, who are deeply anesthetized. It's a little glottic pillow. It's a round circular pillow that fits over the glottic opening, and then when you inflate the cuff, that seals that area, and when you blow into the top, the air has nowhere to go but down into the lungs. The trick with inserting a laryngeal mask airway, and you should be able to try this in class, is that once you get it into the mouth, when you're looking certainly at C and D in this diagram here, this picture of the LMA being inserted, is that you may need to use your finger to reach down inside the mouth as you pass this tube to make certain that the tip of the LMA doesn't fold over. The King LTD, the LTD just stands for laryngeal tube disposable. And these are certainly examples of first-generation Kings where it is a disposable. You've got a yellow for those patients who are 4 to 5 foot tall, a red for 5 to 6 foot tall, and a purple for 6 foot on up. They even have a green and a gray for smaller patients as well that have now received FDA approval. When placed, the King airway, you have one balloon to inflate. When you inflate that one pilot balloon, a large oropharyngeal cuff expands and seals the oropharynx, and then a esophageal cuff inflates and seals the esophagus. So when you blow into the tube, between the two balloons, the air comes out and has nowhere to go but into the trachea. A highly effective airway, easy to insert, not much trauma, 30 centimeters of pressure over the other airways, and is the only FDA-approved airway that can be placed on a mechanical ventilator. Now, with endotracheal intubation, certainly that's always been the gold standard of airway management, but most research shows that EMS really struggles with their ability to intubate. It is indicated for patients who cannot protect their own airway because it is the only airway that guarantees no aspiration. It's used in patients that you can't ventilate with a bag valve mask, may be used in patients with airway obstruction, and if you're going to be bagging a person for a long period of time, then the need to advance the airway to a endotracheal tube is important, because no matter how good you are with a bag valve mask, eventually it's going to lead to gastric distension, the stomach's going to fill with air, and it is going to increase their likelihood of vomiting. Certainly, if somebody's not trained to do endotracheal intubation, that's one of the contraindications. Endotracheal intubation requires the use of a laryngoscope handle and blade, and there are a variety of different blades, Millers and Macs, and they come in a variety of different sizes. They come in standard sizes. They also come in blades that have light source on the end. Other blades rely on a fiber optic light source. Excuse me. And here's an example of how a laryngoscope and a Macintosh could be used to remove a foreign body airway obstruction along with some McGill forceps. And as I had mentioned, there's several sizes of blades, two types. There's a Miller blade, which is often referred to as a straight blade, and then there's a Macintosh, which is often referred to as a curved blade. And I remember those because Miller has two L's, the L's are straight, and that's just how I remember them. Now, the whole important process of endotracheal intubation requires you to select either a straight or a curved blade, but then to also appreciate where the tip of that blade ends up. When you insert a laryngoscope into somebody's mouth, the idea is to march down the tongue. And when you get to the base of the tongue, pick that tongue up to see if you can't identify some landmarks like the epiglottis. If you're using a straight blade, it would go just beyond the epiglottis and pick it up so you can visualize that glottic opening with the vocal cords. Or if it's a curved blade, once you visualize the epiglottis, place the tip of that blade above the epiglottis into the vallecula, and then when you raise it up, it lifts the epiglottis up off the back of the throat. And so that's what they're demonstrating here with a curved as compared to a straight. As far as the other equipment that's necessary, you're going to need an endotracheal tube, and they come in a variety of sizes that accommodate a neonate all the way up to an extremely large adult. After a certain size, in children they may come uncuffed, but adults they all are cuffed. And you use a syringe to inflate the cuff, and the pilot balloon that you see there in the picture, when that's pillowy soft and full of air, you know that your cuff has enough air in it. One other thing that you might certainly consider to have available when you're intubating is a stylet. A stylet is a malleable piece of metal that is sterile, covered with plastic that fits inside the endotracheal tube and allows you to bend the endotracheal tube into a shape that allows you to facilitate intubation. And then having suction available, because once you put that blade into the throat and lift the tongue up, there may be some secretions that need to be suctioned so that you can identify the airway. Once a patient is intubated, and again you'll be doing this in lab, a couple things need to occur. One certainly is proper tube placement, and there's a variety of devices out there that would allow you to determine proper tube placement. One device is called an esophageal detection device. And it's either a bulb syringe that fits on the end of an endotracheal tube or a larger syringe that fits on the end of a endotracheal tube. And if you place an endotracheal tube and it ends up into the esophagus and you've not ventilated your patient, when you pull on that syringe or you squeeze the bulb and let go, the negative pressure that is created will suck that esophagus around the end of your ET tube, and you won't be able to draw free air, or the bulb will not inflate. And that's an indication that you are, in fact, in the esophagus. The issue with these esophageal detection devices is that most people don't employ them until after they've ventilated the patient, after they've placed the tube. And if I put the tube in the goose, I put it in the esophagus, and I ventilate the patient, and it's in the esophagus, it's going to dilate the esophagus and fill it full of air. So when I go in with my endotracheal or my esophageal detection device, I am going to draw free air out, which would be misleading. Once the endotracheal tube is in place and it's confirmed, and end-tidal CO2 monitoring, as you'll learn, is 100% specific and 100% sensitive for the placement of an endotracheal tube. So that's what we want to use rather than an esophageal detection device or a colorimetric device. But once the tube is confirmed to be in the proper place, then securing it with tape or securing it with a commercially available device is recommended so that the patient isn't extubated. To do oral tracheal intubation, at first you need to make sure that you have proper personal protective equipment in place, that you're able to open the patient's mouth, that it is clear and free of secretions, that you're able to auscultate breath sounds when you ventilate them with a bag valve mask to establish a baseline and identify that you in fact can ventilate them. Then you're going to assemble your equipment. You're going to grab the proper size blade, and a 4 or a 3 typically is the size of blade that you'll use on an adult patient. But you're going to assemble the laryngoscope, you're going to attach the blade to the handle, and when you bring it up to a 90-degree angle after attaching the blade, the light will come on. And you need to make sure that the light is bright and tight. Those bulbs may work their way loose and could come off and fall into the patient's throat and maybe even be lodged in their airway. Then you're going to grab the appropriate endotracheal tube size, and most women can accommodate a 7.5, and most men can accommodate an 8. That's just a rule of thumb that I use when doing an intubation. And then I'm going to put a stylet, that malleable piece of metal, down the center of the tube. I need to make certain that the metal doesn't extend beyond the base of the tube because it could cause trauma as you're inserting it. And then I want to leave a little curl on the top of the tube so I can grab that stylet and remove it once I have proper tube placement. I'm going to check my equipment to make sure that it works properly. I'm going to put them into a sniffing position and then open their mouth and determine how difficult it is to do the intubation. Now, I've not paralyzed this person. I've not done anything like that. I'm just getting a good visual of how much open space there is inside their mouth. If they've got an extremely large tongue, if they've got lots of soft tissue, if they've got a short neck, a big beard, lots of dental work, buck tooth, all those sort of things are going to make the patient extremely difficult to intubate. One of the things that I must accomplish when I do intubation is to line up the 3 axes that exist. You got the oral axis going straight down as you're looking at your patient lying flat on their back. You got the pharyngeal axis that goes at almost a 90-degree angle, and the laryngeal axis that goes at a 90-degree angle to the oral axis. And the idea is to position the patient so that these 3 axes are pretty much in line, giving you a straight shot into the airway. And this is a much often neglected step, and a big reason that people can't properly be intubated is that nobody ever put them into the proper position to begin with. Once you've got the patient properly positioned, you've already oxygenated him. This is, again, an unresponsive patient who has no gag reflex. You're going to advance the blade into the mouth. You're not going to bury it to the end and then move things around and manipulate stuff to see if you can't find the glottic opening. You're going to march it in slowly, just beyond the teeth, using the tongue as your guide. You're going to work your way down the base of the tongue, lifting gently until you see the epiglottis, little leaf-shaped muscle. And when you see the epiglottis, then you're going to, depending upon what kind of blade you got, if you got a curved blade, you're going to stick it above the epiglottis into the vallecula. But if you've got a straight blade, you're going to go beyond the epiglottis and pick it up. You're going to move the blade of the laryngoscope towards the ceiling and towards the toe so that you lift that soft tissue up out of the way so you can view the glottic opening in the vocal cords. What we do not want to do is use that blade as a fulcrum. We don't want to bring the blade back towards us because that increases the risk of pressing the blade on the top teeth and snapping the teeth off. Once you visualize the glottic opening, you're going to pass the tube on the right side of the blade and watch it as it goes through the vocal cords. Here they're showing you to grasp the ET tube with the right hand, bring it into the right side of the mouth, advance the tube through the glottic opening until the distal cuff disappears past the vocal cords. Make note of the depth of the tube. Typically on adults, the tube should be no deeper than 19 to 22 centimeters. Once you know that you're in the right spot and you visualize the end of the endotracheal tube passing the vocal cords, you can remove the stylet and then ventilate the patient. Here they're using an esophageal detector device prior to ventilating, which would be the right thing to do if you're using the esophageal detector device. Attach your BBM, ventilate, listening over the stomach first. And the important part of listening over the stomach first is that if I put this tube in a goose and I placed it into the esophagus, I want to get it out of there as quick as I can, ventilate my patient, and try again. So I'm going to listen over the stomach first, and if I hear gurgling and bubbling as I squeeze the bag mask and the chest doesn't rise, I know I'm in the stomach and I need to remove the tube quickly, ventilate my patient, and then try to intubate him again. Again, hooking up end-tidal CO2 is by far the most accurate. It's 100% specific. It's 100% sensitive for the placement of an advanced airway. Using a colorimetric device can really be misleading. Some people will do that initially until they can get them hooked up to an end-tidal CO2. There's essentially 3 colors you're going to see on a colorimetric device. Yellow means yes, you're getting back some CO2. Tan means tentative, you're getting back some CO2 but not enough. And purple is pull the tube, you're not getting back any CO2. So some people will use this, but research has shown that these devices are no more effective than watching the chest rise and fall and listening to lung sounds. Again, remember to note the depth of the endotracheal tube at the patient's teeth and then secure it with tape or some sort of commercially available device. You can't talk about endotracheal intubation without mentioning end-tidal CO2 monitoring. We want to look at both capnography and capnometry. Capnography is the graph or the waveform that you see here on the right, and capnometry is a number that is displayed. And the number is directly related to ventilation. In fact, the end-tidal CO2 number is inversely proportional to the ventilatory rate. So if my end-tidal CO2 is high, that means my breathing is too slow. Whereas if my end tidal CO2 number is too low, that means my breathing is too high. And we need to adjust our ventilations then in order to keep that end tidal CO2 relatively normal, somewhere between 35 and 45. End tidal CO2 monitoring is 100% specific and 100% sensitive for correct placement of an advanced airway. Secure it in place with a commercially available device, or certainly with tape, and then reassess to make sure that we haven't pushed the tube further in during the taping of the tube or during movement. Complications include bleeding, mucosal necrosis, and barotrauma. Bleeding comes from aggressively trying to pass the tube. Mucosal necrosis comes from too high a cuff pressure. Many services are using manometers and are keeping the cuff pressures just high enough to seal the trachea so that you can get air into the lungs, but not so high that within 24 hours they cause necrosis. Normal tidal volume is somewhere around 10 milliliters per kilogram of ideal body weight. But once we have an endotracheal tube in place, we can drop that normal tidal volume to 6 or 8 milliliters per kilogram. So we can reduce the amount of how much we squeeze the bag and how much air we deliver once the patient is intubated. And when you get an aggressive, inexperienced EMS provider who's emptying every bit of that 1,200 milliliter bag into your patient who weighs 90 kilos, they're only going to need essentially half that, maybe 450 milliliters of air, and you're putting 1,200 in there. As a result, it's going to lead to barotrauma. Laryngospasm, laryngotracheal edema can occur, particularly in patients that have any sort of gag reflex. Vocal cord damage from shoving the tube in when the cords are closed. Aspiration, if the cuff isn't fully inflated and the patient vomits, they can aspirate that into their lungs. Intubating the esophagus certainly is a complication, and recognizing that quickly is so vitally important. Placing the tube, more than 22 centimeters at the teeth, the tube itself may then end up in the right bronchus, and the issue with that is you end up ventilating only one lung. The tube itself can become occluded with mucus and as a result lead to hypoxia and dysrhythmias. Certainly those heavy metal blades with aggressive fulcrum on the teeth and the jaws and the lips can cause soft tissue trauma, and there often is a slight increase in intracranial pressure when you intubate a patient, particularly if it takes you several attempts to get it done. Pediatric intubation, slightly different from the standpoint that the tidal volume is much smaller, quite different in the fact that the equipment is much smaller, but we're still going to insert the laryngoscope blade just like we do an adult. Once the tube is in place, we're going to verify placement, and then we're going to secure it with some sort of commercially available device. Now, nasotracheal intubation is going through the nose, and this is a procedure that certainly has lost favor, but when you've got a patient who has some part of a gag reflex but is unresponsive, this is an airway that they may tolerate. The problem with the nasotracheal intubation is that the patient does have to be spontaneously breathing in order to be successful in placing this airway. Digital intubation. Digital intubation is the use of digits to reach inside the mouth and guide and direct that airway anterior so that it does slide into the right place. Digital intubation is not within the scope of practice of a paramedic. The transillumination technique is using a lighted stylet, with the concept being that as I pass the tube by the vocal cords, I can light up the throat with a lighted stylet that would indicate I'm in the right spot. And then a gum elastic bougie, an extremely important tool and should be part of every airway management kit. When you've got a patient that it's very difficult to visualize all the anatomy associated with intubation, but you can see just the base of the glottic opening. You can't identify the pillars. You can't identify the false chords or the true chords. You can't even see beyond the epiglottis. In these cases, if you load a elastic bougie into an endotracheal tube and you pass that bougie first and identify proper placement with the bougie, then you can just slide the tube right over the bougie and into the glottic opening. It's a pretty slick technique and something that certainly we'll practice in lab. Now, rapid sequence intubation is a procedure that has been highly debated in paramedicine. Intubation itself has been highly debated, and there was a period of time a couple years ago where in Iowa an attempt was made to eliminate the ability of paramedics to do rapid sequence intubation, because at that point in time the research just showed that paramedics weren't really good at intubating, and gosh forbid we then, if you weren't good at intubating, give you the ability to paralyze somebody, take away their ability to breathe, and then not get their airway, which could lead to the need for surgical cracothotomy. But through research that I conducted, as well as a couple others, we were able to validify that in fact paramedics in Iowa can do rapid sequence induction, apply it appropriately, and make a difference in outcome. So it did stay in the protocol. It's something that is just touch and go every time they revise the scope and every time they revise the standards. It's just something that you've got to be a relatively high-performing service to be successful at rapid sequence induction. And there's nothing rapid about it. As you can look here, there are 7 Ps that need to occur prior to intubating the patient. And preparation may take you up to 10 minutes to get everything in place prior to administering the medications. You want to pre-oxygenate them, put a mask on them at 15 liters by non-rebreather, and that certainly, again, displaces the nitrogen and increases the amount of time that you have to do this procedure. Now, pre-medication is something that's rarely done. Pre-medication is, if it's done at all, we're seeing it done in children, where you might give a child some atropine to help dry them up and blunt the powerful vagal stimulus that occurs when you intubate somebody, which in pediatric patients could slow their heart rates way down. So, we typically don't pre-medicate with atropine, typically don't pre-medicate with lidocaine, and typically don't pre-medicate with a non-depolarizing paralytic, which then would prevent the fasciculations that you see occur when you give succinylcholine. Prior to paralysis, we are going to sedate the patient, and there's a variety of meds that are used for sedation. Certainly etomidate is one, Versed is one, ketamine is one, propofol is one, and depending on the given situation, your medical director may favor one over the other, but it is so extremely important to sedate the patient first and then paralyze them. Now, once you have the patient paralyzed, excuse me, it's getting a little dry, I need a drink of water. Once you get the patient paralyzed, you need to protect the airway because the patient is no longer breathing. And if they were to aspirate, and they're not going to forcefully vomit because all their muscles are paralyzed, but they may passively ooze vomit into their airway, it could end up in their lungs. So you need to protect the airway. You need to get them intubated, pass the tube, and then confirm placement quickly after paralysis occurs. The standard medication used for paralysis in most services is going to be succinylcholine. And the reason that it's used is that it works quickly. It works really fast, but it doesn't last long, and that's vital because if you're unable to intubate the patient and you've taken away their ability to breathe, if you can't ventilate them effectively with a bag valve mask, they will die. So you need to pass the tube, get it placed, and if you're unsuccessful, have a backup plan. And if you are successful, certainly look at post-intubation management, which includes, confirmation of tube placement, securing the tube, oxygenating, hooking on end-tidal CO2 and pulse oximetry. So indications for rapid sequence intubation include a person who's working really hard to breathe and might be in respiratory failure. A patient who's not a candidate for CPAP or that CPAP fails, a combative head-injured patient or drug overdose patient requiring airway control, somebody with uncontrolled seizures or status epilepticus, somebody with a complete airway obstruction, somebody with severe head injury that's unresponsive, severe asthma that is unable to breathe, and then somebody who has inadequate central nervous system control of their own breathing. Probably the two most common or the three most common complications associated with rapid sequence induction, and one of the reasons that it was called to be removed from the paramedic scope of practice is if you're taking too long to do the procedure, it can lead to apnea, and the prolonged apnea can lead to bradycardia, hypoxia, and hypotension. And those sort of things certainly cause poor outcomes in your patient. Fasciculations or muscle tremors that occur with certain types of paralytics. We have paralytics that are non-depolarizing paralytics like vecuronium. Non-depolarizing paralytic doesn't cause fasciculations, where succinylcholine is a fasciculating paralytic. It causes muscle fasciculations or severe muscle tremor prior to paralysis, and it's that severe muscle tremor that may cause an increase in potassium release, which could raise your potassium level and could cause some problems. Another complication associated with rapid sequence induction is death from not ventilating the patient, low blood pressure from severe hypoxia, that high potassium levels from the fasciculations, an increase in intragastric pressure, and malignant hyperthermia is a medical condition that occurs in patients who often receive succinylcholine or fasciculating paralytics. It's not so common in non-depolarizing paralytics or non-fasciculating paralytics like vecuronium. But the issue with vecuronium, if that were the drug of choice to start this process, when I give vecuronium, the patient can be paralyzed up to 40 minutes. And if I'm not able to get them intubated, that can really be a challenge when I attempt to ventilate them. Whereas if you're using something like succinylcholine, it has an extremely short half-life, and those patients may stay paralyzed for about 6 or 8 minutes, and then they start breathing on their own. When doing a preparation, we need to assess whether or not this is going to be a difficult intubation. And if the intubation is going to be difficult, and this is something that you can accomplish at the hospital in a more controlled environment, then that would be the recommendation. But if there's a need to perform the rapid sequence induction in the field or the rapid sequence intubation in the field using the Mellon-Potty class score to determine the difficulty of intubation would be something that you should do. A class 1, of course, is an easier intubation. You have the patient stick their tongue out. Again, these are patients who are conscious and can obey commands, but there's a need to intubate them. You have them stick their tongue out, and if you can see the uvula and the pillars and the whole back of the throat, that's a class 1. If you have them stick their tongue out and the pillars in the back of the throat where the tonsils lie are starting to become obscured, that's a class 2. When you have a stick their tongue out, you can barely see the opening, barely see the uvula, That's a class 3. And if you have them stick their tongue out and all you see is their upper palate, then that's a class 4, which would indicate an extremely difficult intubation. Let's go back to this slide. So evaluate the Melon-Potty. Hook up a cardiac monitor and watch for bradycardia as you do this. Hook up a pulse oximeter, looking for hypoxia for prolonged attempts, bradycardia for prolonged attempts. You want to pre-oxygenate them. Again, pre-oxygenating them flushes the nitrogen out of their system and extends the amount of time you have to do the intubation. And then pre-medicate them if that's what your protocol calls for, pre-medicating them with something like atropine to dry them up, to blunt excessive vagal tone from the intubation, as well as lidocaine, which is supposed to reduce intracranial pressure. But I don't know anybody using those sort of pre-medications. And then we need to consider sedation with paralysis. We always want to make sure that our patient is deeply sedated before we paralyze them. You know, taking away somebody's ability to breathe is, if they're conscious and awake, just has to be a horrific, frightening thing for that particular patient. So we want to make sure that they're deeply sedated prior to taking away their ability to breathe, So our sedatives are going to include things like etomidate and ketamine and Versed. Versed and etomidate are most commonly used around these parts, at least where I'm from, because they're certainly effective. Versed is a benzodiazepine, etomidate is a barbiturate, and etomidate puts them down harder and deeper when compared to Versed. But etomidate does have cardiovascular effects, and using ketamine then eliminates those cardiovascular effects of drop in blood pressure, release of histamine, that sort of stuff. Then the paralytic of choice, primarily in this area, is going to be succinylcholine. Succinylcholine has a full page of contraindications, but most clinicians would agree that in an urgent situation where you need to intubate somebody, succinylcholine is your go-to drug. It paralyzes them for a short period of time, allows you to get the patient intubated, and then they wake up and start breathing on their own, which is important, because if I paralyze them with vecuronium or rocuronium and they're out for 40 minutes, if I'm not able to ventilate them and they can't breathe for the next 40 minutes, that can really be detrimental. Protecting the airway is what you do with the endotracheal tube. They talk about cricoid pressure here, but cricoid pressure, putting a thumb and a finger on either side of the larynx and pushing straight down to occlude the esophagus, is just something that is no longer recommended. And the primary reason for that is that it just isn't being performed properly, and in improper performance of the cricoid pressure procedure or the Selleck maneuver, you can actually make it more difficult to pass the endotracheal tube through the trachea. But once the tube is in place, you need to verify placement with both visual means, seeing the tube pass the vocal cords, seeing the chest rise and fall, listening to breath sounds, as well as secondary confirmation with things like end-tidal CO2 and a chest x-ray. Secure the tube in place once it's there so that it doesn't become extubated. The equipment that you're going to need for endotracheal intubation includes personal protective equipment, oxygen, suction equipment, an antiseptic. Oh, here they've jumped completely from endotracheal intubation and securing the tube to doing a needle cricothyrotomy. When attempting to do a needle cricothyrotomy, it's important that you assemble this sort of equipment: personal protective equipment, because it can be bloody, oxygen, suction, an antiseptic to clean the throat, an adapter from the top of a 3mm ET tube that you can put on the end of the Jelco once it's in proper place, so that you can hook up a bag valve mask device and attempt to ventilate your patient. When we do a needle cricothyrotomy, at best it is designed to oxygenate your patient, not ventilate them. In order to ventilate them, we need something like a quick trach, which is within the scope of practice of a paramedic, or a surgical cracothoratomy, which is within the practice of a critical care paramedic. So, indications for cracothoratomy: difficult or impossible intubation, complete upper airway obstruction from a fractured larynx, craniofacial abnormalities that would not allow you to intubate the patient through the nose or the mouth, congenital laryngeal anomalies that would prevent the tube from passing, excessive oropharyngeal hemorrhage, massive genetic congenital deformities of the upper airway, and then respiratory arrest. Contraindications: if you can ventilate the patient with a bag valve mask, obviously there's no need to do a cracothoratomy. It requires you to identify the landmarks of where you're going to place that needle, and if you're unable to identify those landmarks, then certainly that's a contraindication. If they have a primary laryngeal injury where they strike their throat on the steering wheel and crush their larynx, that may be a contraindication to a cracothoratomy. And then infralaryngeal obstruction. If they've got a massive obstruction in the larynx, it's going to be difficult to pass the needle. Cracothoratomy allows for rapid entrance to the airway for temporary oxygenation. It really doesn't allow for ventilation. We're finding that although we used to believe that you could ventilate a patient through a cracothoratomy, that just really isn't the case. A needle cracothoratomy opens up the trachea so that you can hook up oxygen to it and that you can oxygenate your patient who's breathing on their own. Now, there are needles that you certainly can use, a very large, 3-inch, 14-gauge needle that you can use when identifying the landmark and placing it into the neck. But there's also trocanters, easy trachs, that allow the paramedic to insert a tracheostomy with a very large trochanter, which would actually allow you to ventilate the patient with a bag valve mask. The site for the needle cracothoratomy is between the thyroid and the cricoid membrane. And in some services, you might have to have medical director approval to do it. To do a needle cracothoratomy, the patient should be lying supine, hyperextended, manage their airway, check their pulse oximetry, check their heart monitor, check their vital signs every 5 minutes. Prepare the equipment by palpating the neck and locating the cricothyroid membrane. Cleanse the site with whatever you're cleaning the site with a syringe and a needle in your dominant hand. Stabilize the larynx and then insert the needle into the larynx while pulling back free air. And when you can pull back free air, then you're in the larynx. And that's a confirmation of that. Now you notice here that they're starting the 14-gauge needle towards the lungs rather than towards the head. Once you insert the catheter to the hub, then you can remove the needle, and you can hook up your 3mm ET tube on the end of your Gelco, which would allow you to use a bag valve mask to try to ventilate the patient. This is one method. Certainly there are commercially available transtracheal jet insufflators that use your oxygen source within your ambulance to instill oxygen at a great force, which may actually ventilate the patient. Okay. Put a 4x4 gauze pad around the catheter to stabilize it, tape it in place, and then auscultate the lungs to make sure you're in the right place. Here's that quick trach or easy trach that I was talking about, where you can use that larger trochanter on the end of that syringe there, punch a hole in the throat, and there are metal barbs on either side of that catheter that allow you to, run that holder or run that material through those metal barbs and tie it around the patient's neck. To do a surgical cricothyrotomy, I just have to mention that this is not within the scope of practice of a paramedic, but certainly is something that you should be aware of. If you go on to be a critical care paramedic, it is within the scope of practice of a critical care paramedic. You want to put the patient in the same position that you would to do a needle cricothyrotomy. You want to find the cricothyroid membrane. You want to make an incision with a scalpel, and then you want to spread that tissue apart, and then you want to make an incision into the cricothyroid membrane, and then using the curved hemostat or the bottom of your scalpel, stick it in that hole and twist it sideways to increase the diameter, and then place an endotracheal tube towards the feet in that opening. Now, certainly you're not going to go at 19 to 22 centimeters at the opening, because that would put this tube into the left to right main stem bronchi. Once you get the tube in place, inflate the pilot balloon so it seals, and then ventilate them with supplemental oxygen. Confirm placement with endotracheal or with end-tidal CO2 monitoring. Tape the device in place. Now, pulse oximetry certainly has its limitations, and we talked about this when I was there a while back, where pulse oximetry can give you a false reading. Pulse oximetry tells you that the hemoglobin that you have is saturated with a gas. It doesn't tell you anything about ventilation. It doesn't tell you anything about the amount of hemoglobin that you have or what gas is saturating that hemoglobin. Pulse oximetry is indicated for all patients who have any sort of respiratory problem, but you can get a faulty reading if the patient's hypovolemic or anemic, because again, the pulse oximetry doesn't tell you how many red cells you have. It just tells you the ones that you have are saturated with the gas. It can be get a faulty reading in dark-skinned patients. You can get a faulty reading if the patient's moving around a lot, if the probe is dirty or the finger's dirty, if the batteries are low or there's bright overhead lights, if the patient is smoking cigarettes or has suffered from smoke inhalation. In that particular situation, smoking cigarettes or smoke inhalation, they're more than likely going to have breathed in some CO, some carbon monoxide. And patients with carbon monoxide poisoning may have a carboxyhemoglobin level of 40 or 60%, where 40 or 60% of their red cells are saturated with carbon monoxide, but the pulse oximetry doesn't differentiate that, doesn't tell you that. And patients who have really cold extremities or who are in shock don't have a good blood flow in order to pick that up. The pulse oximetry, again, gives you no indication of the patient's ventilation, doesn't tell you about their tidal volume, doesn't tell you about their respiratory rate. It just tells you that they're oxygenating or that they do have oxyhemoglobin present. Doesn't tell you how many hemoglobin molecules are present, but that they do have some. Oximeters give you no information about the level of carbon monoxide or the level of CO2, and therefore have limitations in assessing a patient who's developing respiratory failure due to CO2 retention. So if you've got an extremely large COPD patient who's short of breath and you lie them flat, one, they're going to struggle to breathe just because of their size and the fact that you've lied them flat, but then they're going to retain more and more CO2, which could lead to respiratory failure. And that's not anything you're going to pick up with a pulse oximetry. It gives you no information on the oxygen content of the blood. It gives you no information about the amount of oxygen dissolved in the blood. It gives you no indication about the patient's cardiac output or blood pressure. Again, it just tells you that a portion of it tells you that what hemoglobin you have is saturated with a gas. If there are no waveforms on your pulse oximeter, if you've got a pulse oximeter that has a bouncing graph or has a heart that flashes or a light that flashes, when you see that flash or you see that graph or that bar go all the way to the top with the light, that's indicating that the pulse oximeter is sensing a pulsatile flow. If the pulse oximeter doesn't recognize a pulsatile flow of blood through the digit, then the readings that you're getting are meaningless. Pulse oximetry is a lag monitor. In other words, the oxygen levels will fall a great deal before you actually see a change in the number. In fact, the lag can be up to several minutes. Really be leery of immediate changes in pulse oximetry. You know, it's just physiologically impossible to immediately go from 99% O2 sats down to 85%. You want to look around and see if perhaps the probe has come off, that sort of thing. And remember to always treat your patient, not the pulse oximeter. Some practical tips for the use of pulse oximetry: make certain the batteries have a good charge. Wait for it to go through a calibration before you attach it to your patient. Select the right size probe. Remove any fingernail polish, any oil or dirt from the nails of the person's digit. Position the probe to avoid excess tugging or force on the digit itself, and allow time to detect that pulsatile flow and calculate the saturation. Look at that pulse oximeter to see if there's a bar that's flashing, or a light that's flashing, or a heart that flashes. And if in doubt, certainly use your clinical judgment. One thing that's important as a paramedic that you can determine the effectiveness of the pulse oximeter and how accurate it is. Many pulse oximeters will display the heart rate. Well, if the heart rate on the pulse oximeter doesn't equal the heart rate on the heart monitor, or the heart rate that you're palpating when you palpate their pulse and determine their heart rate, then the numbers that you're looking at are inadequate. Exhaled CO2 monitoring. Again, I can't stress enough the importance of end-tidal CO2 monitoring in airway management. It has drastically changed the way in which we manage airways, and now that we can bring this technology into the field. It's used for ET tube verification, 100% specific and 100% sensitive. Related to tube placement. The pulse oximetry also gives you an idea of how well your patient is ventilating. CO2 is a direct reflection of perfusion to the lungs, and does measure effective ventilations. Pulse oximetry measures oxygenation, where end-tidal CO2 measures ventilation. So it gives you an adequacy. It gives you an idea of how adequate your ventilations are if you're ventilating your patient. It gives you an idea of how adequate perfusion is to the lungs. It tells you how effective your chest compressions are, as we'll see in ACLS, and it tells you whether or not you get a return of spontaneous circulation, like we will see in cardiac arrest as well. A capnometer is a device used to measure the concentration of CO2, and it gives you the number. A capnographer, or a capnography, is a continual analysis, a continual breath-by-breath recording of CO2, and is displayed as a graph. Capnometry is the numeric reading or the number, and a capnograph is the waveform. End-tidal CO2 detectors, we talked about colorimetric devices and how they really are no more effective than watching the chest rise and fall and listening to lung sounds, but certainly there still are people that use that. By far, capnography is the most important thing that we can use to quickly and breath by breath measure whether or not our tube's in the right place, whether or not our CPR is effective, whether or not we need to speed our breathing up or slow our breathing down in our patients. Exhaled CO2 monitoring includes a variety of different devices, an exhaled CO2 detector like your colorimetric device or an actual qualitative end-tidal CO2 monitor. CPAP, continuous positive airway pressure, is another extremely important aspect in airway management. It is positive pressure throughout the entire respiratory cycle. CPAP involves PEEP, which is positive end expiratory pressure, and normally we'll set our CPAP at least 5 millimeters of mercury, and we'll increase it quickly to 7.5 all the way up to 10 millimeters of mercury to help improve the work of breathing that our patient is experiencing. BiPAP is like CPAP, but it is dual pressures at different levels. We don't see a lot of this occurring in the pre-hospital environment because there just really isn't a small portable BiPAP unit. But where we do see it certainly is in the emergency department on, let's say, for example, a COPD patient who's been working really hard to breathe. They'll put those folks on BiPAP, and they'll do something like 10-5, which might indicate, 10 of inspiratory pressure and 5 of positive end expiratory pressure. So with BiPAP, you have more pressure coming in than you have going out. So it's not a ventilator. In other words, it's not, BiPAP isn't going to ventilate your patient, but it will make it easier for them to take a breath. If the pressure is greater going in, helps them fill their lungs more, and then when they exhale against a lesser pressure, it does stent their alveoli open and allows them to oxygenate. So indications for CPAP: chronic respiratory failure, congestive heart failure with acute pulmonary edema, pneumonia, asthma, emphysema. Although not well studies in those conditions, certainly preliminary research would show that it is a benefit to use CPAP in those situations. It helps stents the alveoli open and lessens work of breathing. And anytime you can lessen work of breathing in somebody that's working hard to breathe, it's going to go a long way. CPAP is non-invasive, it's easily adjusted, it's easily discontinued, it's comfortable, there are minimal complications, it doesn't require the patient to be sedated. However, if you have a patient who's extremely anxious, there's nothing wrong with giving them a little sedative and then talking them into using the BiPAP or CPAP. And CPAP is now within the scope of practice at the EMT level in Iowa. Alert patients with an intact gag reflex who are short of breath is when CPAP is indicated. Those with congestive failure, those with drowning, inhalation exposure, COPD, asthma, pneumonia. Although it's not commonly used in trauma, it certainly can be. The issue with CPAP in trauma is that those excessive airway pressures in a pneumothorax could change it into a tension pneumothorax. Other indications for use of CPAP include that severe CHF, severe COPD, severe asthma, respiratory rates greater than 25, working hard to breathe, using their accessory muscles, SATs less than 88%, hearing all kinds of noises. The important part about CPAP is that the patient must be able to maintain their own airway, and they must be able to follow commands. If this person is obtunded in any way or unresponsive in any way, then we have to go to intubation. But a tremendous improvement was seen in patients who initially would have been intubated but were instead put on CPAP, and in about 10 minutes it just showed major improvement in their ability to breathe. You should be cautious with CPAP in patients with pulmonary fibrosis. In a person who's claustrophobic, they're just not going to be able to tolerate the mask. And so you may have to coach them. You may have to, again, consider mild sedation in those folks. If the person has failed at past attempts for non-invasive ventilation, then CPAP might be an option. Some cautions include the patient who complains of nausea or vomiting, because it could indicate that their belly's filling up with air, and you wouldn't want them vomiting if wearing the mask. If they have excessive secretions, they're not really a candidate. If they've got facial deformity that prevents a good seal, they're not a candidate. And CPAP, while very beneficial in many patients, it's not without risk. Higher pressures can cause a pneumothorax. Certainly if it helps their esophagus expand and their belly fill up with air, it increases their risk of vomiting and aspiration. If it causes intracranial pressure to rise, or if it causes intrathoracic pressure to rise, then that can lead to hypotension. And then the constant blowing by the eyes can cause corneal drying. Some exclusion criteria for CPAP: if their pressure is less than 90, if they're not conscious or their respiratory rate is inadequate, if they are in respiratory or cardiac arrest, if they're unable to obtain an adequate seal, if they've suffered major trauma to their face, if they have a pneumothorax, if they have a head injury, if they've got a GI bleed, if they're actively throwing up, these are not people that you'd want to use CPAP for. There's a variety of CPAP devices, some machines that help blend the amount of oxygen, but they do have a tendency to drain the system quite quickly of oxygen when you use these little transport CPAP devices. Many people are going to that far right-hand corner is an indication of a type of airway that is plug and play, a type of CPAP where you just put the mask over the face, and based on what you crank your flow rate at determines your PEEP. All right, in summary, we did all the things that we said we were going to do. We looked at upper airway and what it consisted of. We looked at the lower airway and what it consisted of. We talked about ventilation and respiration, both external and internal respiration. We talked about the body's need to remove carbon dioxide. We talked about being able to identify that the patient is in respiratory distress rather than respiratory failure. We talked about listening to lung sounds and what that might tell you. We talked about the importance of administering supplemental oxygen when necessary. Talked about the devices for delivering supplemental oxygen. We also talked about airway obstruction and what the causes are, as well as how to open airways, the importance of ventilating patients, particularly if they're apneic, and then the advanced airways that are out there, to include a combi tube, an LMA, a King airway, an endotracheal tube. We looked at nasal tracheal intubation as an often not frequently used but highly effective airway. We looked at rapid sequence induction. We talked about capnography and capnometry. We talked about pulse oximetry and its benefits, as well as CPAP and its benefits. We looked at cricothyrotomy as an emergency airway procedure in the event that intubation or some sort of supraglottic airway device fail. And with that ends Chapter 14, and we're going to wrap this up. And the next time we talk, we'll be in Chapter 22. And Chapter 22 is your cardiovascular chapter, and will take us actually clear through the rest of the year. It's a wonderful, amazing chapter on a wonderful, amazing organ that of all the body parts is one of my favorites. So with that, I'm going to sign off, and I will talk to you soon.